all for joining us for the GW Biomedical Cross-disciplinary seminar series. This is a relaunch. We took a little hiatus because of the COVID pandemic, so we thought it was appropriate to relaunch with a talk about COVID and inflammation, inflammation being our topic for the year. This is going to be an annual series that explores a cross-disciplinary topic, a new one each year. And our goal is to promote networking and collaboration from different disciplines to shift the paradigm. And we're hoping that we can do that online. So this will be the first time we've had an online one. We're going to leave lots of time for questions at the end to help with that interaction so we can get to know who's here and what everyone is doing. So please keep questions in mind as we move forward. Without further ado, I will introduce our speaker for today. Dr. Hana Akselrod, MD, MPH, is currently the Assistant Professor of Medicine in Division of Infectious Diseases at George Washington University School of Medicine and Health Sciences. Prior to joining the GW Medical Faculty Associates, or MFA, as we call it, because that's much easier to say, she trained in internal medicine in Portland, Maine. She completed her MPH training in epidemiology and biostatistics and the Climate Change and Health program at the Yale School of Public Health. At GW, she's been active in medical education, serving as a faculty mentor in the quality improvement and the clinical public health curriculum programs. She conducts research on HIV and aging as part of the DC Center for AIDS Research and DC Cohort Longitudinal HIV Study. She's also kind of become the resident GW expert on COVID. So we're looking forward to hearing what I was calling Beyond COVID 101. So we've heard the COVID 101 talk from Dr. Akselrod, and now we're looking for 102. Thank you, Dr. Akselrod.
Thank you so much, Lee. I don't know what to tell you. It's very strange to live in a world where a lot of people now seem to share my obsession with viruses. So for better or for worse, here we all are. And I would like to leave some time at the end of this discussion for time to talk a little bit outside of clinical medicine and outside of our immediate interest about how we as an institution can think about the inflammatory aspects and the long-term risks of COVID-19 together. I will give you a little overview. We're going to start with a background on viral infection and inflammation. A lot of what has been published so far on COVID-19 focuses on acute infection and the response to it, but we will shift to talking more about the long-term consequences of this infection, both in the individual body and to us as a society. And for disclosures, no dogs were forced into masks for this talk. I just like this picture. I don't have any financial investments or conflicts of interest. I am a co-director of the new COVID-19 recovery clinic at the GW MFA, and I'm a co-investigator on studies currently working on the Moderna vaccine trial, and earlier did some work on an AbbVie protocol for interventional therapeutics against COVID-19. I do share some preprint information and investigational uses, and I will note when the information I'm discussing does not come from a peer-reviewed source. So without further ado, so my focus during this talk and my perspective is primarily as a clinician. So apologies in advance to any immunologists on this line, as I will be oversimplifying things to the point of where, as a clinical physician, I can understand them. So what we know about the courses of viral infection, inflammation, and immunity to SARS coronavirus 2, which causes COVID-19, is in a large way based on what we knew about SARS-CoV-1, the virus that causes SARS, and the other coronavirus in its family that causes the Middle Eastern Respiratory Syndrome disease, or MERS, both of which were known as viral infections that triggered severe disease with acute respiratory distress syndrome being common. ARDS is a condition associated with fatal outcomes in a high proportion of cases, and mortality was reported as about 10% for SARS and about 35% for MERS. The immune response to these viruses was known to involve both damage to the physical barriers of the respiratory tract, as well as activation of the innate and adaptive immune systems. And this bears spending a few minutes on. So the physical barriers that are damaged in the course of respiratory viral infection is the physical barrier of the epithelial cells that line the respiratory tract, which can lead to the disruption of those airways and introduction of the virus to deeper tissue. The innate immune pathway has to do with activation of the cytokine pathways, in which chemical signals are released by the cells that are being damaged in order to attract the innate immune response. That's our macrophages, our neutrophils, our cells that are supposed to phagocytose or engulf damaged cells, as well as the pathogen. This involves increasing in the permeability of the lung blood vessels, the lung vasculature, which makes the entire system leaky and can cause it to fill up with fluid, but eases the way of the innate immune system to respond to the infection acutely. And then in a close interplay between the innate immunity and the adaptive, some of the immune cells that are attracted to the site that has been damaged are the dendritic cells, which are activated and present antigens or bits of protein and segments derived from the pathogen for recognition by the T cell system, which activates the B cell system, which produces antibodies, which then go out into circulation and attempt to neutralize and stop further reproduction of the pathogen. So that's our extremely simplified immune response to a respiratory viral infection. So what we know from what was known as of the beginning of this pandemic, based on experience with SARS-CoV and MERS-CoV, is that the activation of this immune response with antigen-specific antibody production does persist for at least several months after infection, but also that the immune response as a whole may be limited despite the production of antibodies. And also in the acute phase, there seemed to be a decrease in the circulation of macrophage and T cells that were circulating in response to the infection, which also might delay or limit the immune system's ability to clear these viruses. The mechanism of this was never clarified with SARS and MERS because both of these epidemics were contained before too many cases were investigated in such high detail. So, a word on the cytokine pathways. So I put this slide up to express why I find immunologists who understand and remember these pathways so intimidating. The cytokine response pathways are incredibly complex with an interplay of pro-inflammatory and anti-inflammatory or regulatory signals. They may differ by the family of virus that is triggering the initial infection, but the common thread is that the introduction of a respiratory virus triggers a strong pro-inflammatory cytokine cascade, predominantly with IL-6, IL-8, and TNF-alpha, and as well as an interferon response. And one more piece before we go into details on COVID-19, one more piece I wanted to share is that there have been instances of viral infection triggering chronic lung disease. This is one example from an animal model study in which paramyxovirus was used to look at first how an initial, in this case IL-13 triggered response recruited immune cells acutely into the lower airways to clear the virus. However, several weeks later, when the same mice were retested, the immune response had shifted to a natural killer T cell response, which activated macrophages in a more enduring pattern, which produced chronic inflammation and lung disease similar to asthma or COPD in humans. So this is from a different viral family, but I'm sharing this as an example of what viral infection can do in the long run. Right, so briefly, how did we get here? So this is not a repeat of what Lee calls COVID-19 101, but in the transition from a predominantly animal circulating virus to now pandemic human circulating virus with ongoing community transmission in many countries. At this point, with over 30 million cases in the world and nearing 1 million deaths, there have been enough people who recovered from this virus to produce a large number of reports of people who actually experience long-term consequences of this disease. And as we try to untangle what this means, we want to be thinking about what has to do with direct damage from the viral infection and what has to do with more enduring activation or changes in the immune and inflammatory response. Right. So this is this morning's snapshot of where the pandemic is. And as you see, the US is no longer responsible for 1/3 of daily deaths, but we are by no means out of the woods. This is the heat map of where viral transmission is most active right now, with cases going up still in multiple states in the Midwest. The decline in daily cases has somewhat plateaued over the month of September, and the decline in deaths has also seemed to stick around. And just a word on the maps. So for some of my data visualization, I do use lay sources. This is from the New York Times. I don't love doing it, but I think we can in medicine learn a thing or two from the journalists about how to make figures intuitive and easy to understand. So SARS-CoV-2 infection and acute inflammation has been a concern from the start. And as a brief review, the entry of the virus into the cells of the respiratory tract is mediated by the binding of the spike glycoprotein to ACE2 receptors, which we think of primarily as receptors in the airways. However, ACE2 receptors are also found throughout the epithelial cells of many systems, including the respiratory tract, but also the gastrointestinal tract, also the kidney and heart tissues, and also the ACE2 receptors are present on endothelial cells which line the blood vessels. And this is going to be key when we talk about what happens on the micro level in blood vessels in this disease. There is a secondary role to another transmembrane protein in mediating the cell entry. There is less information available about it so far as to its role in inflammation. So we're not going to focus on TMPRSS2, but I do note that it is there. Right. This is from a recent review in one of the Nature journals about the inflammatory pathways that are triggered by SARS coronavirus 2. So in the immediate response, IL-6 and TNF-alpha are heavily involved and can be detected at high levels. More generalized cytokine release syndrome or cytokine storm in severe cases involves the entire range of pro-inflammatory cytokines, including IL-6, IL-1 beta, GCSF and GM-CSF. And some of these have been investigated as targets for immunologic modulatory therapy. The pathway that is activated by IL-6 includes the JAK receptor, which is the target of a drug called baricitinib, which is currently showing some promise in therapeutic studies. I won't go into a lot of detail specifically on all of these immunomodulatory drugs, not only because the data is somewhat mixed to date, but also because it would need a few hours. But generally speaking, in the subset of people who get very severe infection with COVID-19, we have been thinking from the start about how to interrupt the cytokine storm before or when it happens and decrease the inflammatory and immunologic damage that ensues. From the very start, and this is one of the first series reported from Wuhan, the key presenting features of this disease we have known were fever, cough, and shortness of breath or difficulty breathing. And in a relatively high proportion of cases, out of the ones who ended up in the hospital, progression to acute respiratory disease syndrome. Not necessarily at once. This ARDS was not the presenting syndrome for most of these cases, but in the patients who progressed to it and required ventilation and ICU care, mortality was quite high. As we learn more about the disease, there were some attempts to classify different levels or types of damage to the lungs, and some of this has implication on ventilator management, although it's not easily translatable to critical care practice. But conceptually speaking, there seems to be an early phase of the disease in which there's a lot of direct viral damage to the lung tissue, but the lung can still expand and contract somewhat normally, and its microarchitecture is not affected. And these patients do well with high-level oxygen supply, but without needing to be put on ventilators, without needing high pressures of oxygen being forced into their lungs. In more advanced disease, there is more inflammatory damage deeper in the lung. The lung becomes heavy, dense, filled with fluid. The lung tissues may infarct due to microscopic blood clots, due to a very inflamed and procoagulopathic picture. And mechanical ventilation is then needed to support this lung. And once people get into that stage of disease, the mortality early in the pandemic was more than 50%. Now it's closer to 40% with improved ICU management and improved use of steroids. But there's still a lot of bad outcomes. Right, and these are again some of the cytokines that are measured and can be high in the ARDS phase of the disease. And the image is actually part of a video you can watch on YouTube taken by Keith Mortman, one of our cardiothoracic experts at GW. And he really walks you through what happens in the lung in severe COVID-19. The common thread is all of this inflammation in this very delicate tissue fills the alveoli with fluid, destroys some of its barriers, and there is a sense that the immune response is very dysregulated. So we may see decrease in CD4 and CD8 T cells and B cells, which are supposed to be responsible for the adaptive immune response. We see dysregulated ratios of neutrophils to lymphocytes, and we see very high markers of inflammation, such as high sensitivity CRP and procalcitonin. So what this means in the clinical setting, what this means to me as a physician, is that when patients seem to be worsening overall with this disease, with high fever, worsening or increasing requirements for oxygen, and we start seeing evidence of multi-organ damage or inflammatory damage to the heart, the lung, the kidneys, and the liver, you may see changes in serum markers of all of these organs at the same time as inflammatory markers going high. And then what happens to, in the long run is between the inflammation, the fluid, and the high oxygen pressures required to keep those lungs functioning and keep the body and brain supplied with oxygen, we actually see a high incidence of more physical damage to the lungs, and parts of the lung can actually rupture, fill with air, leading to a pneumothorax, or a collection of air in the lung. So this does not happen in every case of COVID-19, but in one British study looking at 71 cases from across the country, of the patients who experienced this complication, the majority were on vents, and another 20% were on vents plus an extracorporeal membrane oxygenation or a total circulatory bypass system. So even though 63% of these patients with these severe pulmonary complications survived, their ability to regain pulmonary function and quality of life is expected to be affected for a long time to come, if not permanently. And then looking at when this happened to patients who were over age 70, there was a significant decline in their ability to survive the disease. All right, so lung damage was one of the early concerns. Then direct and indirect damage to the heart has also been with us for quite some time. There are kind of three types of cardiac injury we think of, and one is direct infection of the muscle fibers of the heart by virus, as well as toxicity from high levels of inflammatory cytokines and a pro-inflammatory state. So it was thought that this viral myocarditis and acute myocardial toxicity happens either in very severely ill patients, but with a kind of a predilection for younger patients. I will get back to that in a minute. And then what happens to patients who are acutely ill, who are in ARDS, who have this all over body cytokine storm, they can actually get toxicity and damage to the myocardium from the cytokines and from immune-mediated damage. And then kind of on a tertiary but more widespread level, people who already have cardiac disease are known to have worse outcomes with COVID-19. Some of it may be adding stress to a heart that is already prone to rhythm disruptions or to having a myocardial infarction or heart attack. You put extra stress from any cause on someone whose heart is not 100% and is vulnerable to heart attacks, and you may tip them over the edge. So the presence of pre-existing cardiac disease has been known to be a risk factor for worse outcomes. So getting back to the direct myocardial damage, this is further trying to figure out why up to a quarter of patients with COVID-19 can have evidence of heart dysfunction. So this was an in vitro study in which cardiac-derived muscle fiber cells were combined in a petri dish with samples of SARS coronavirus 2. And the researchers actually showed in real time invasion and destruction of the myocytes and an increase in fragmented myocytes or destroyed myofibrils. And they showed kind of similar patterns in autopsy specimens of people who had COVID-19 and died, with the thought that damage to the heart might have been one of the reasons they died. This also goes along with some recent cardiac MRI studies of relatively healthy young people, athletes who got infected with COVID-19 and had a decrease in cardiac function after. So while this speaks more to direct damage, you have to think about what this does in the long term. The immune system has to clear the damaged cells and the disintegrated cellular debris, causing possibly a more prolonged inflammatory picture. All right, and then one other vital system that is damaged by both by the virus directly and by high circulating levels of cytokines is the kidneys. So, so I mentioned that kidneys themselves have ACE2 receptors, making them the tissue vulnerable to viral injury. But what at least one large-scale study showed was that in patients who came into the hospital and didn't have renal injury, but were already infected with COVID-19 and sick enough to require hospitalization, during the course of their stay in the hospital, their kidney function deteriorated at about the same time as their inflammatory markers shot up. So this, again, is consistent with this picture of cytokine storming as being the mediator of multi-organ damage. And then we look at the microscale at what happens in blood vessels. And starting in late March, April or so, there have been reports of damage on the cellular level due to clotting and inflammatory damage to the blood vessels. And this may be because endothelial cells that line the blood vessels have ACE2 receptors and can be damaged themselves by this virus. But what's thought to be contributing is that an inflammatory all over body response increases the tendency of blood to clot and to form microscopic clots in the circulation of vital organs, which can then exacerbate any injury from the virus itself. Some of the presentations reported in New York City initially with relatively young people who didn't have any known risk factors for stroke, but came in with large blood clots in the setting of being infected with COVID-19. That really highlighted just how much the blood clotting system is disrupted by levels of inflammation that are this high. And one of the questions was the robust inflammatory and immune response that young people have actually a risk factor for these blood clots apart from the virus? And this is yet another pathology study showing that it's actually an ongoing process that can happen in the lungs of people infected with COVID-19. So not only does the inflammation and the thrombosis cause damage to people who have severe COVID-19, but the body actually starts to generate new blood vessels and produce angiogenesis to try and restructure the circulation of the lung tissue on a microscopic level. All right, so the next question is, we get this damage from the acute inflammatory response and the innate immunity with high levels of cytokines and the disruption in the recruitment of immune cells to the tissue. But then the adaptive immune system does kick in and does start to produce specific antibodies against this virus. And we know that not all antibodies that we produce in the setting of an acute infection are neutralizing antibodies, which will have the ability to clear the virus. But in several studies, the level of neutralizing antibody production in COVID-19 infection has actually been promising. So over 95% of people studied in one notable study did produce a neutralizing antibody response, and this response persisted for several months, although the levels of the neutralizing antibodies did decline after the third month or so. And this is not to say it all went to zero, and the magnitude of the response differed a little bit by how severely ill people were. What is interesting is that people with asymptomatic infection still produced antibodies, including neutralizing antibodies. But the people who were severely ill had consistently higher serum levels of the antibodies, both initially and when followed 3 to 4 months out. So this suggests that on one hand, the immune system, the adaptive immune system does kick in more powerfully when people are severely ill, despite whatever limitations and dysregulations to the immune cells we observe. But on the other hand, people who have asymptomatic or mild infection can still produce at least some protective antibody, even though it may be present at a lower level and fade faster. So one question this raises on the population level is, at what point in time does that protective immune response fade completely to a point where it's no longer clinically meaningful? And the second question is, what happens when people get infected for a second time? Is the immune response more attenuated? So hopefully giving us a way to avoid this very severe initial response with a lot of cytokine-mediated damage? Or might there be more rapid production of the neutralizing antibody the second time around, resulting in clearing the virus faster before it has time to do much damage? So that would be the best case interpretation. The nagging concern is, and this has been raised a couple times over the course of the pandemic so far is, what if there is an enhanced antibody response the second time around, but what if it actually results in clinically more severe disease? We haven't observed this to date from the couple of known cases of reinfection that have been reported. It's not at all clear that that happens, but we are keeping our minds open, and this part of the book is still to be written. All right, and then we get to the antibody and mediated damage. So this is probably best known in the context of the severe inflammatory disease that children can get with COVID-19. So it's been described as a Kawasaki-like disease, or as a multi-system inflammatory response in children. And it is thought to be primarily an antibody-based clinical presentation, when children who initially had mild or asymptomatic infection with COVID-19, several weeks later developed this kind of all-over immune hyperactivation syndrome. It is somewhat similar to macrophage activation syndrome, which is another overreaction by the immune system to a disease that it recognizes, handles, and then cannot turn itself off, and ends up damaging tissues diffusely, including blood vessels, and including the potential for cardiac damage. So while this is a rare complication in children, this is one of the biggest fears with schools being reopened and a lot of children possibly exposed to the virus in the months to come. Not only do we have to think about the possibility of a small number of children that will get severe enough disease to require hospital care. And by the way, the study on the right in the Journal of Pediatrics was published by a group out of Children's National and affiliated with GW here and our MITM department. But you also have to think in the long run about the long-term effects of myocardial damage at an early age to the health and development of children for the rest of their life. Right. One more kind of bit about inflammation and COVID-19 is that we've known all along that obesity and metabolic syndrome are associated with worse outcomes in this infection. In analyses based on CDC numbers, as well as international studies, metabolic syndrome itself, so that it's the combination of obesity, high cholesterol, and prediabetes or diabetes, or abnormal glucose metabolism, the metabolic syndrome together significantly increases the risk that someone infected with COVID-19 will have severe illness and prolonged ICU admission and death. There is a sort of dose response effect with obesity, in that people who have stage 2 obesity with a body mass index of over 35 are relatively worse off with COVID-19 relative to stage 1, relative to people who are overweight but not obese, and then yet again relative to people who are normal weight. There is more than one mechanism by which obesity can correlate with severity of COVID-19, and there's a reason I put this slide in my inflammation talk. A lot of these mechanisms overlap with the inflammatory cascade. So we know coagulopathy, the propensity of blood clots, is associated with higher levels of inflammation. We know that people who have obesity have a less robust T-cell response overall. That part of the immune system can be attenuated or decreased in its capacity. Whereas their cytokine response profile, that's the innate immunity, and the non-specific response can be more robust, more powerful, and might lead to more damage in the acute phase of the disease. And then once people get to a stage of COVID-19 severe enough that they need ventilation, their underlying difficulty breathing in extreme cases of obesity can make it more difficult for them to come off the ventilator. And the high correlation between obesity and cardiac disease can trigger complications such as type 2 heart attacks, which are essentially heart attacks triggered by extra stress that the heart muscle can't handle. So between the propensity with obesity to have dysregulated inflammation and the more severe consequences of the physiologic damage in people who are obese, we may explain why there's such an increase in severe outcomes. But the bigger context for all of this is that, at least in our country, obesity can correlate with poor access to healthcare, poverty, and also stigma when people do access healthcare. And I'll unpack this a little bit. So people need access to financial resources to have a healthy lifestyle. And they also need to be able to go to the doctor and feel like they have their concerns taken seriously. And people who live with obesity, especially extreme or morbid obesity, do frequently report that they feel judged when they seek medical care. So that not seeking medical care until the disease has already done a lot of damage may lead to worse outcomes by itself. It is very hard to untangle which part of this is responsible for how much of this increased or excess mortality with obesity and COVID-19, but it gives us a lot to work on. All right, so really briefly, this is another overview of the targets of drug development and therapeutics in COVID-19. So we think about blocking cell entry. So ideally, this would be something like Tamiflu for flu, a drug that can decrease the ability of the virus to enter the cell and then to replicate in it. We think about the inflammatory cascade that we've been discussing as something we can intervene on, and that's where steroids act, and where some of the other immunomodulatory drugs it can act. Passive immunity by transfusing someone immunoglobulins or antibodies from another person is another way to fight this infection. And then the introduction of active immunity through vaccinating before someone gets infected is our holy grail. And then I like putting supportive care, getting better at the type of critical care we do for people who have COVID-19. There have been real changes in clinical practice since we first met this virus. For example, we, having learned more about how the lungs function in this disease, we no longer intubate people early. We try to give them supportive but non-damaging pressures of oxygen first. And we have learned things about what doesn't work that we're able to avoid now. For instance, we now avoid hydroxychloroquine or chloroquine, which were initially thought to maybe decrease viral replication or decrease inflammation in people with COVID-19. But as more data came out, it turns out there was no measurable benefit to clearing the virus, not in a clinically meaningful sense, but there was measurable risk of causing irregular heart rhythm, leading to more cardiac complications in the same patients. So we no longer do that. All right. So it is hard to keep track of every single study on every single interventional therapeutic on COVID-19. Fortunately, the NIH has treatment guidelines that are vetted by experts and updated relatively regularly. So currently, I mentioned the recommendation against the use of hydroxychloroquine, and ivermectin, which is an antiparasitic drug, is in that same category of drugs that were thought to maybe interfere with viral replication or inflammation, and there's just no good evidence that it works. There, for now, is a recommendation against the use of specific IL-6 blockers to try and block the inflammatory cascade, and I'll get to that in a minute. And right now, even though the FDA granted an emergency use authorization to convalescent plasma, which is the attempt to give passive immunity with transfusion of antibody from someone who recovered, when we look at the data, there are enough difficulties with getting high quality neutralizing antibodies in convalescent plasma, that as a whole, this treatment is not reliable. What does seem to have specific and measured, although kind of modest benefit, is remdesivir, which is an antiviral that specifically blocks viral replication. I will repeat that it's not a miracle drug. It has an impact on mortality in people who are sick enough to require oxygen, but not so sick that they are already on a vent. And we think that has to do with the phase of infection in which antivirals are most effective. So you want to block viral replication early on. Once somebody's in that cytokine storm mediated multi-organ dysfunction state, clearing the virus a little bit faster, unfortunately, it's a little late for that, because at that point, most of the damage is done by the non-specific immune response itself. So that is why we think that early short courses of remdesivir, if it works, that's when it works best. Right. Dexamethasone seems to be more useful. This is steroid treatment, seems to be more useful once people are in the stage where they have moderate to severe disease. So that's people who are requiring oxygen, including high volumes of oxygen, and people who are ventilated. So the recovery randomized controlled trial out of the British healthcare system showed a significant benefit to survival, even in people who were sick enough to be ventilated, and then several other trials support their findings. This makes sense because steroids interfere with the non-specific inflammatory response. Tocilizumab, I have this up as an example of an IL-6 blocker. It's not the only one. Sarilumab is another one. But the upshot of now several studies with tocilizumab and others in its category is that it can block parts of the cytokine storm pathway. It will lead to measurably lower measures of inflammatory markers, but its effect on disease mortality, disease severity, and outcomes is not very impressive clinically. And then you have a trade-off in which you are actually blocking the ability of the immune system to mount response to other infections for some time to come. And we're talking days to weeks to come. IL-6 blockers can also disrupt the gut-blood barrier, which makes it more likely that bacteria that are meant to be inside our bowels can translocate to the blood, cause bacteremia and sepsis from a bacterial source. And also people who are sick enough to be receiving these drugs are in the ICU already. They have lines going into them and tubes, and they can become infected through those. So clinically speaking, the IL-6 blockers have not quite borne out their promise. There is another class of inhibitors, the JAK inhibitors, that might have more promise, and we look to updates on those in the weeks to come. So convalescent plasma I mentioned briefly. So it's the idea that if you introduce neutralizing antibodies from an external source, you can block some of the, you can clear the virus faster. One of the issues with me and my colleagues experienced in practice when we gave this treatment through the Mayo Clinic protocol and the American Red Cross system is that by the time you get a matched unit of plasma to your patient, they're usually already severely enough ill that they're in that inflammation-mediated phase of the disease. And you are also unsure of whether the bag of plasma you're receiving from the blood bank has adequate neutralizing antibodies to make a real difference. Any blood transfusion product that comes from another person on its own actually introduces immunogenic material into the person you're giving it to. And there have been ICU studies in which blood transfusions related to worse survival in the long run when adjusted for other factors. The thought on that is you're introducing something that's immunogenic into people whose circulatory system and lungs are already very vulnerable. So if you don't know for a fact that it's going to help them, it's best not to give it. All right, then we get to the long-term consequences, and this is a picture of Niagara Falls. Paul Sachs, who is one of the leading infectious disease physicians at Brigham and Women's, writes a blog on infectious disease observations. And he, at one point in spring, kind of compared trying to keep up with COVID-19 research to trying to drink from Niagara Falls. And I'm very flattered when, Lee, when you called me a COVID-19 expert. I think at this point, the ability to become a COVID-19 expert just relates directly to how much sleep you're willing to skip while staying up late reading. So one of the emerging areas of research in COVID-19 is the duration of symptoms after the acute infection. It is a little bit difficult to get a clear bearing on what proportion of people with COVID-19 experience symptoms more than a couple months out, in part because it mixes together two things. So one is patients who have severe illness of any cause who require ICU care and ventilation can frequently get we call it post-ICU syndrome. You get myopathy and neuropathy of critical illness, where people not only lose muscle bulk from being inactive for weeks, but also the high levels of cytokines and inflammation can be destructive to muscles and toxic to the nervous system. So it takes weeks to months to recover after an ICU stay, regardless of why you were there. But then with COVID-19, there's the question of, it appears to be a disease of dysregulated immune response. How much of that dysregulated immune response actually continues after viral infection? And does it occur in people who have mild illness or moderate illness who never needed to be in the ICU? And the answer appears to be yes, but we don't know what proportions, and we don't know who is most at risk. Young people seem to not be immune to this. And this does take us back to the robust antibody response and the possibility of a pediatric or Kawasaki-like syndrome, but it can also happen in adults. Right. And then we think about who these consequences are happening to. So I mentioned the overlap between obesity and inflammation. And people who have obesity already having dysregulated inflammatory response, which in part affects or is triggered by the lipid metabolism, and in part affects how they respond to every other infection. For instance, people who have obesity have more severe disease with influenza as well. This is a map of heart disease rates across the country in red on the left, but it overlaps very closely with a similar map of obesity and also of stroke risk, to highlight that these are systemic, obesity and inflammation are systemic risk diseases. The chronic inflammation we observe with obesity affects blood vessels, not just in the heart and the brain circulation, but also on a microscopic level. The map on the right in blue is the CDC's Social Vulnerability Index score. And this was through a study done a number of years ago, looking at where in the country on a county by county level are people more socially and economically predisposed to worse medical care and worse medical outcomes from any cause. So that includes low education, higher distance to medical care, such as rural counties where you have to drive for hours just to get to a hospital. So you really, or a specialty office, and you really think about, really think about the investment of going for that medical care. So there is a lot of overlap in our country epidemiologically between social and economic barriers to care, obesity and heart disease. And if you looked at a map of where COVID-19 was striking the most over the summer, the pattern would look very different. The pattern would look very similar to this, with the exception of northern New England by then being over its peak. one of our concerns, and I just haven't seen the data summarizing what happened over the summer and what consequences there are to the health of people in these regions who survived COVID-19. But one of my suspicions is that we will see more long-term consequences to health due to an overlap of severe disease with severe immunologic response, but also lower quality of care or access to care, and higher co-occurrence of pre-existing heart and lung disease. All right, couple slides as I wrap this up. So this is a closer to home picture of where kids tested positive for COVID-19 around DC. And the higher incidence of positivity overlaps both geographically and in terms of socio-demographics with lower income. We know that COVID-19 functions as an amplifier of racial and ethnic disparities in health in the US. And this is really stark when you look in the figure in the upper right, how many people died of COVID-19 in each group so far. One of kind of the biggest underlying drivers of inequality in health outcomes and health disparities in this country is pollution and environmental triggers of chronic disease, which overlaps with historical practices of redlining, in which people who were poor, people who were Black and discriminated against in housing policies, and people who experienced higher rates of chronic disease, all ended up being people in the same neighborhoods. And you add a higher incidence of COVID-19 in neighborhoods that have more essential workers or low-income workers, and you kind of get a perfect storm. And then in a study from the psychology and psychiatry fields, lifelong discrimination and chronic stress levels actually ties in with chronic inflammation and risk of atherosclerotic disease or heart and lung disease in the long run. So yet another perspective on why we may see more severe COVID-19 in populations that are historically marginalized and experience poor quality of life. So what comes next? So I have a modeling study from half a year ago at this point, showing, based on figures from China, that after kind of the initial wave was controlled, if you remove the social distancing and safety measures before there is immunity to this virus on the population level, you get a second wave pretty quickly. And this requires us to think not in terms of not only immediate response, but also ongoing survey and surveillance and repeat responses, not just on the level of the individual immune system, but also our public health system needs to be doing the same thing. All right, so I mentioned reinfection case reports. Just briefly, it seems to be a real but so far rare concern. And the explanation for this is not only do antibody levels drop off after 3 or 4 months, but the virus, this is not thought to be because of significant mutations in the virus, but there might be just enough of a drop off in individual antibodies combined with just enough of a change in the virus that together some number of people will get reinfected. What this means on the population level, we're not so sure, but what this means from the point of view of working on a vaccine is that rather than a vaccine people get once, like our childhood vaccine series, this may well be a vaccine we have to repeat every year. All right. So the impact of initial mobility restrictions was quite dramatic in saving lives, but then what we've observed ever since then is that we need to stay vigilant and to continue to try and bring our population level transmission down to a level where you could test, trace, isolate, and support, or Tetris, new re-emerging outbreaks. And then you have to figure out how to keep the rest of the medical system operational, because all those chronic diseases that lead to worse outcomes with COVID-19, they can also kill people on their own. Right. One huge area of concern out west right now is what the wildfires and the smoke and air pollution from those does to the risk of COVID-19, both in terms of irritating and inflaming the lungs, making them more vulnerable to viral infections, but also diverting resources to responding to the wildfires away from other areas of public health, as well as forcing people to evacuate and be displaced for a long time. All right, so at GW, we have research work on every level, everything from clinical trials to community outreach to registries and specimen banks set up. And we're trying to think of how this impacts our educational mission, our ability to educate students, but also to give students an opportunity to be colleagues and active actors in how we respond as an institution. So a couple news items featuring GW are, this is a patient I helped take care of in the hospital early on, who has actually become a great advocate for raising community awareness of COVID-19 after surviving the ICU. And the other thing we've been working on in terms of community outreach is to improve trust between the DC Black community and enrollment in clinical trials to make sure that the vaccines that are being tested are both safe and effective for the people who are at highest risk of worse outcomes if they get this disease. All right, we want to continue prevention, so hand washing, social distancing, masking. Just really briefly, yes, there is some airborne transmission. The CDC is struggling with how to phrase this right now, I understand, but universal masking decreases both large and small droplets. So if we can all do that for the months to come, we will decrease transmission. There is even some suggestion that universal masking may increase the proportion of cases that are asymptomatic, that get a low enough dose of the virus that their immune system can react appropriately, but not overreact. And then we are thinking of how to shift from an acute response to maybe a sustained effort in which we use all of the resources and insights at our disposal to deal with COVID-19 as a threat that emerged this year, but whose impacts are felt on the basis of inequities and structural factors that have been there all along. So where I want to see research on inflammation and COVID-19 go is both in the specific immunologic response to this virus and more on the role of inflammation and chronic disease and poor health outcomes on the population level. Thank you very much for the opportunity to give this talk. And I give this back to Lee.
Yes, thank you so much. That was very interesting. And I like how you covered so many different aspects of both the patient, our environment, the immune system. It really is a very far-reaching disease, and I think challenges the way we've been thinking about diseases previously, which is probably a good thing. We are running a little short on time. If someone has a question, I would just say go ahead, unmute yourself, and throw it out there.
Hey, this is John Pan. I'm a 76-year-old. So what do you think I should look forward to in the sort of coming months in terms of what's going to be the new norm?
So thank you, John. I think you look forward to your family stocking up on masks whenever they want to visit you. I think it's realistic to get through this pandemic and to get to a point at which it is controlled and we can get more of our lives back in a 1 to 2 year time frame, but that assumes public cooperation and assumes public health measures on a large scale. I have a 90-year-old grandmother who asks me twice a week when she can go and mix freely with friends in restaurants again. And I feel like a terrible granddaughter because I keep telling her not yet. However, we are making advances. We may not be able to eradicate this virus in the foreseeable future, given how entrenched it is at this point on the world level. But if we get a vaccine that confers some degree of protective immunity that can at least decrease the risk of severe disease, we keep building on what we've learned about antivirals, wait for more antivirals. We want something better than remdesivir. We want something that can be taken orally. Like Tamiflu, for instance, early in the disease to prevent it from getting more severe. And we are honestly talking and thinking about culture change, how we think about social interactions, moving more things outdoors, improving ventilation, deciding what really needs to be in person. Can this meeting be a Zoom or an email type thing? And it is not easy to adapt. And as an educator, I think the quality of teaching does suffer, but we as a species are incredibly adaptable, and we can find a way through this.
I think that's the perfect note to end on. We will be innovating to adapt and overcome. So thank you all for joining us so much. And just to say it out loud, this is being recorded and it will be available on the seminar's website. You can actually just Google cross-disciplinary seminar and GW and it pops right up, or it will probably be coming out in a future email. So enjoy the rest of your day and stay safe.
Before
Yes.
you let everybody go, why don't you tell them the date and the topic for the next lecture?
Sure, I'll have to look that up. Okay, it is October 22nd, Thursday, noon to 1 p.m., and it's with Sana Syed from the University of Virginia, and it's going to be about bioinformatics and inflammation, so big data and how we can use that to both study and hopefully help treat inflammation.
I'll be there.
Excellent. All right, hopefully see you all again soon.